Right, our next speaker is Dr. Katherine Colman from Victoria. Dr. Colman is a Paediatric Oncology Fellow at the Royal Children's Hospital in Melbourne with a particular interest in paediatric leukemia and stem cell transplantation. As a Mark Track scholar, Dr. Colman has commenced a PhD this year at the Walter and Eliza Hall Institute of Medical Research, investigating chemotherapy resistance in paediatric acute lymphoblastic leukemia, and is working in novel drug discovery. Their presentation is titled BH3 Mimetics, Highly Effective in Relapsed or Refractory Paediatric Acute Leukemia, Real-World Experience from the largest Australian centre. So I'm just going to do your right.
So every year in Australia, there are 280 children diagnosed with leukemia. And while we have well-evidenced frontline therapies, unfortunately, 12% of children with acute lymphoblastic leukemia or ALL relapse. And for kids that relapse, the long-term survival ranges from 50% of those with B-ALL to only 20% of infants. For children with acute myeloid leukemia, AML, the outcomes are even worse, with 40% of kids relapsing and 1 in 3 of those surviving long-term. Most relapses need a bone marrow transplant as the only chance of cure. But we know that the lower your leukemia burden prior to transplant, the better your outcomes. But for many children, they are unable to achieve the required remission to progress to their life-saving transplant. Often this is due to chemotherapy resistance. So one solution is to target this with venetoclax. This is a novel chemotherapy agent developed in adult leukemia that targets BCL2, one of the guardians of cell survival. And this allows the leukemia cell to die via the normal apoptotic pathway. There are some small phase 1 trials of venetoclax in kids, but very few talk about transplant. And we know that clinical trials don't always reflect the wider population due to strict inclusion and exclusion criteria. So we wanted to know, what is the real-world experience of venetoclax? We did a retrospective review of 18 children who were treated with venetoclax as a bridge to transplant at our centre. At a balance of ages and genders, and half of children were treated for AML, just over a quarter for ALL, and the remaining patients for treatment-related leukemia after having already survived a previous childhood cancer. Children had a wide range of leukemia burdens, including up to 90% of their bone marrow being leukemia cells, and half of the patients, or the ones in red, had what we call frank disease, so more than 5% of their marrow was leukemia, with the remaining having measurable residual disease, or MRD disease, less than 5%. And patients were heavily pre-treated, with a median of 2, but a range of up to 5 prior lines of chemotherapy, including 4 previous transplants and 9 previous immunotherapy. And despite this, we had excellent outcomes. We had 16 of the 18 children obtaining a complete remission, of which 2/3 were MRD negative, so no disease even down to a molecular level. 3/4 of children were able to progress directly to their bone marrow transplant, with 1 child declining a transplant and another 2 needing further chemotherapy prior to their transplant. Only 1 of the 18 kids was not able to progress to his transplant. And this occurred at a really rapid time frame, at a median of only 32 days from the first dose, allowing kids to move to transplant at a median of 2.5 months. This Kaplan-Meier curve shows our 2-year overall survival was 78%, with event-free survival of 42%. Even out to 4 years, our overall survival was more than 50%, which is way better than that graph I showed you on slide 1. And this was a really well-tolerated therapy. No child had to stop venetoclax due to side effects, and the median quality of life score was 80 out of 100. This is quite a complicated graph, but it basically shows the 18 kids down the y-axis and the time following their first dose of venetoclax in months on the x-axis. Where their bar is red, they have frank disease, and where it turns to blue, they're in remission. Triangles are their bone marrow tests, with red being MRD positive and blue when it changes to MRD negative, so no detectable disease. You can see kids have a short duration of venetoclax in the dots before moving to their transplant in the green donut, and then many go on to have a long period of remission. In fact, 3 of the 4 kids with acute lymphoblastic leukemia are alive, and 1 up to nearly 5 years post-venetoclax. 7 of the 10 patients with AML are alive. All of those 7 are in remission. And even for the children with a secondary leukemia, which classically has a really poor prognosis, 3 of the 4 children are still alive, 2 in remission, and 1 unfortunately really recently relapsed and is undergoing further therapy. So this is exciting progress in what is normally a really deadly disease. This is the largest paediatric single centre experience of venetoclax, showing that it's highly effective in salvaging paediatric leukemia, especially those that are chemotherapy refractory. A really high remission rate of 89%, of which 2/3 were MRD negative, and patients were bridged to a transplant at a rapid timeframe of 2.5 months. This meant it was useful in facilitating long-term remission. And moreover, this is an oral chemotherapy drug that people can have at home and is well tolerated. Further research is always needed to enhance our understanding of therapeutic response, to predict which kids will and won't respond, to optimize rational therapeutic combinations moving forward.